name is Barbara Ganzel. I'm a hospice-trained social worker, a research neuroscientist, and I've been working and publishing on the effects of psychological trauma on the mind, brain, and body for more than 20 years. My full bio is at the end of the presentation. I'll be talking today about a subject that I care about deeply: understanding and addressing psychological trauma in the context of aging, and why it matters for long-term care. This is the first of a 10-part video series on implementing trauma-informed care in long-term care, which I've produced with my good colleague, Paige Hector. This is an introduction to the prevalence and impact of psychological trauma as seen from 3 different perspectives in health: how to recognize it, and special concerns for working with older adults in long-term care. But first, does anybody see this cleverly disguised elephant? I'm saying that unresolved psychological trauma is the elephant in the room here for our long-term care residents and for us as staff, hence all the elephants in this presentation. Because exposure to psychological trauma is common, as we'll see, and unresolved trauma can disrupt the most careful care plan. This is especially relevant for older adults as they move into those last years of life. 100 years ago, we were equally likely to die at any age, and we tended to die relatively quickly from accidents or more or less untreated health conditions. With the advent of modern medicine, we're more likely to die as older adults and to undergo increasingly invasive medical intervention for years before we go. This sets the stage for psychological trauma to be an issue in new and unexpected ways in aging that are rarely addressed right now. I'll be talking about 4 cases today. This is a need right here. She has mid to late stage Alzheimer's. Her language is rapidly deteriorating, and she's becoming combative during personal care. Samuel has end-stage bladder cancer. He's poorly controlled pain and increasing nightmares and depression. Esther has congestive heart failure and COPD, 24 oxygen. She uses a wheelchair. And recently, Esther has stopped sleeping at night, but with no significant dementia. Morty has type 2 diabetes and both feet have been amputated, but it's much better controlled now that he's in care. He's very well liked by staff, kind of a hail fellow, well-met kind of guy. Has 3 children in the area and none of them visit or are involved in care. Staff are experiencing some of these long-term care or hospice residents as bewildering or irritating, and some of the families as frustrating and incomprehensible. All of these cases are composites of actual long-term care or hospice residents that I and my colleagues have encountered in the field. The pictures here are stock photos. Let's talk about the prevalence and impact of psychological trauma. This is a graphic from a study done by the World Health Organization, looking at the prevalence of trauma-level events in lifetime in 24 countries in people between the ages of 18 and 99 years old. They used a relatively restricted definition of psychological trauma, actually the most restrictive, which we'll talk about in a minute. And we are going to focus right now on the United States. Okay, so this was a nationally representative study, epidemiologically correct, amid a very wide age span, again, using the most conservative definition of trauma. And what they found was more than 80% of the population report exposure to a trauma level event in lifetime. This suggests that virtually all of your residents will have a history of psychological trauma or exposure to psychological trauma, and virtually all of your staff, which is a very important consideration for an organization that's working on being trauma informed. Because here's the thing. Most of us are going to experience multiple psychological traumas by the age of 60, and I'll show you those data in a minute. Most of us will have a loved one who experiences trauma. There's lots of different kinds of trauma. In long-term care and hospice care, we tend to think of combat veterans when we think of psychological trauma, but it's not only combat veterans. And all these types of psychological trauma are relevant to long-term care. Let's take a look at sexual assault as one example. A survey by the U.S. Department of Justice found that nearly 300,000 women and 90,000 men are raped every year in the United States. The Center for Disease Control estimated things a little bit differently, and they found that 23 million women and 1.7 million men experience rape or attempted rape in lifetime. So that's annual risk or yearly risk accumulating into lifetime risk. Center for Disease Control also found that about 1 in 3 women and 1 in 6 men experience contact sexual violence, which is a little broader category than rape or attempted rape. These numbers are going to be worse in dangerous environments, in people who have been incarcerated, people who live in dangerous environments because of poverty, or people who are exposed to war or even the military. About 1 in 3 female veterans report an attempted or completed sexual assault during their military service, whether they're deployed or not. There's 3 definitions of psychological trauma that are commonly used in medicine and public health. There's the definition by the Substance Abuse and Mental Health Services Administration, which we're going to call SAMHSA. Also the one by Center for Disease Control, or the CDC, and one by the American Psychiatric Association, or APA. SAMHSA has the broadest concept of trauma as embedded in trauma-informed care. They recognize that trauma is on a larger continuum. The Center for Disease Control uses the ACEs definition. The ACEs consists of a simple 10-item list of adversities that can happen in childhood. They did some of the first work on trauma-informed care with a focus on children. And the American Psychiatric Association, or APA, has a focus on defining trauma-related mental disorder with very specific criteria that need to be met for diagnosis. As noted, our arguably broadest definition of psychological trauma from SAMHSA is that a trauma consists of events or circumstances experienced by an individual as physically or emotionally harmful or life-threatening, with lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. It's called the 3 E's definition of trauma: events, experienced, and effects. This is the definition used by the U.S. Centers for Medicaid and Medicare when they required implementation of trauma-informed care and long-term care in phase 3 of the final rule for long-term care that went into effect in November 2019. This is the publication, the SAMHSA publication that was mentioned by CMS in that final rule. And SAMHSA has expanded the applications of that in its TIP 57, Treatment Improvement Protocol 57, on trauma-informed care and behavioral health. Now let's bounce to the Center for Disease Control and Adverse Childhood Experiences. Adverse childhood experiences, or ACEs, are widely discussed as childhood traumas, and they're the subject of trauma-informed care practices in the US and Canada and around the world, usually to the exclusion of trauma in adulthood. Because note that ACEs only relate to experiences before the age of 18. There are 10 ACEs that are assessed in ACEs studies: abuse, verbal, physical, or sexual abuse, and also neglect, domestic violence in the household, parental separation from one's parents through divorce or death or just leaving home, and then a household member with substance abuse, mental illness, or who has been incarcerated. want to point out here that, put my neuroscientist hat on, brain development absolutely matters in the experience and consequences of psychological trauma. But there's nothing neurologically magic about the legal age of emancipation in the United States at 18 years. Just saying. All right. And there's certainly other types of trauma and adversity that can occur in childhood. For example, growing up in a war zone, as these children are. An important point is that ACEs are not rare, and that surprised a lot of people. In a study conducted in California, more than 60% of adults reported at least one ACE, and more than 15% reported having 4 or more. Similar results have been seen throughout the United States. Vincent Felitti and Robert Anda developed the early research on adverse childhood experiences. The CDC adopted that work, and by 2018, ACEs had been surveyed in more than 230,000 adults from 43 states in the US. And what they have been finding, and it has very important implications for public health, is that early trauma affects long-term health. So ACEs increase the lifetime risk for 7 out of 10 of the leading causes of death in the United States, including cancer, heart disease, COPD, diabetes, to name a few. It also shortens your lifespan. And this happens in a dose-response manner. The more ACEs you have, the more health problems. So dose-response relationship is increase in the exposure to a stressor or stimulus, drive increases in the outcome. Here, the bigger the dose, the bigger the response. For example, people with 4 or more ACEs are more likely to get cancer as adults than people with 1 or 2 ACEs. And this is the ACEs pyramid. So this is the mechanism by which adverse childhood experiences influence health and well-being through the lifespan and mortality. You have adverse childhood experiences. These affect neurodevelopment. This is disrupted, but I would say different neurodevelopment, because it could be adaptive in the short term and maladaptive for health in the long term. You see changes in social, emotional, and cognitive development. You often see adoption of health risk behaviors. But even in the absence of adoption of health risk behaviors, you still see increases in disease, disability, social problems, and earlier mortality, sometimes by as much as 20 years. So accumulating ACEs can impact your body and your health directly, but unhealthy health, behavior like smoking does make it all worse. So this is an example of just one ACE in action as a need approaches the end of her life. She has mid to late stage Alzheimer's. Her language is deteriorating, and she's become combative, as we've seen during personal care. For her family, she's had an appropriately cheery relationship with her caregiver, kind of as if he were a grandson, right? But as her dementia progressed, she became less able to use words, less verbally expressive, and now seems to exhibit rage when her caregiver whistles around her. It's important to do a medical check to make sure that there's not a change in a medical condition that's driving these behavioral changes. But nothing showed up. So the next, staff reached out to the family to see if whistling might be triggering for this resident. So a trigger is a reminder of past trauma. And I've got a whole video on that later on in the series. A trigger is a reminder of past trauma. It produces an involuntary stress reaction, which when staff talked to the oldest daughter, she reported that Anit had been molested by an uncle as a young girl, and that he whistled as he did so. So this is the ACE being molested, and the whistling is an associated trigger. Anit's usual coping skills were less available. Excuse me, it's not COVID. Anit's usual coping skills were less available as her dementia progressed. She faced a more confusing and unfamiliar world. This guy entering her darkened room, whistling while she was lying in bed, was frighteningly familiar. It was a trigger, and it was re-traumatizing. The solution here was to avoid the trigger. Identify it, avoid it. The caregiver stopped whistling around Enid and adopted a softer approach that once again left her smiling when they interacted. So here, Enid was being accidentally re-traumatized and was fighting back accordingly. The solution was to ask the right questions so that staff could figure out and avoid the trigger, so Enid isn't being repeatedly terrified by her care. Here's something a little less simple, if you will. Morty is a double amputee with type 2 diabetes. He has 3 kids in the area, none are visiting. During a phone conversation that became a confrontation between a frustrated staff person and one of Morty's children, the adult child told the staff person that Morty had sexually abused all 3 kids, all 3 of his children when they were young. And that's why they didn't visit, and nor were they going to. Well, the staff reported to her clinical supervisor correctly, and that supervisor now has a lot to think about. First, is Morty going to be a threat to other residents? That's not an impossible situation. It's not an impossibility. Also, what is the minimum information she should add to Morty's medical record to minimize the risk to other residents and also to Morty? It's entirely possible, given the statistics, that 1 or more of her staff members may have experienced childhood sexual abuse and may react poorly to Morty as a consequence. Statistically, too, Morty himself may be a survivor of sexual trauma. Many perpetrators are, and he may need support as such when he declines. There are not a lot of easy answers here, but we can see that it's important that staff know enough about the trauma in Morty's family so that they can take the best possible care of Morty, keep other residents safe, as well as supporting Morty's family and his care providers, some of whom may need to be reassigned. But better information leads to better care. Some people take the ACE's age limit to mean that trauma doesn't matter after the age of 18, and that would be incorrect. Research tells us that every person in this image, that every person in this image is vulnerable to the long-term effects of psychological trauma, no matter how old they are. This person, for example, may be just 18. Mental health definitions of psychological trauma apply to all ages, as does SAMHSA's definition of trauma. The American Psychiatric Association publishes the Diagnostic and Statistical Manual of Disorders, 5th edition, which limits its definition of trauma to certain types of severe or life-threatening events that threaten death, serious injury, or sexual violence, such as rape, serious accidents, or natural disaster. They used to include life-threatening illness. They do not now. These events may occur to yourself. You may see them happening to others, directly experienced, personally witnessed. Some indirect experiences qualify. For example, if your job requires you to repeatedly hear about traumatic events that happen to others, this can result in what's called vicarious traumatization or secondary trauma. As I noted earlier, importantly for clinical care, the APA recently excluded nonviolent death and life-threatening illness from their definition of trauma, which excluded 60% of cases from a formal diagnosis of PTSD. But these patients still suffer clinically significant trauma-related symptoms that could impact their medical care, as we will see next. This is why a broader view is required when assessing and addressing trauma in medical settings. So overall, we see we've got 3 definitions of trauma set by SAMHSA, the CDC, and the APA. They all differ in the kinds of circumstances that they include. However, lucky for us, there's one set of symptoms that serve as key identifiers. So our suggestion is to focus on the symptoms you see. So SAMHSA and the American Psychiatric Association largely agree on what happens to people when they've experienced trauma and adversity too often in their lives. They can develop symptoms that look like these, not all of them, but numbers of them. Okay, physiological symptoms of and signs of psychological trauma are, either past or current trauma or a stressor, are increases in reported pain, muscle tension, headache, the things we know, teeth grinding, increases in blood pressure, increases in heart rate, increased or decreased appetite, changes in bowel function, nausea, stomachache, and so forth. Among psychological symptoms, you have the re-experiencing group of symptoms, unwanted upsetting memories of the trauma, flashbacks of the trauma, emotional distress at trauma reminders, or physical reactivity at trauma reminders. There's also the group of trauma-related arousal or trauma-related reactivities, risky or destructive behavior. This could show itself in a medical setting as people who either want lots of treatment or no treatment. Hypervigilance, heightened startle, trouble concentrating, sleeping, being grouchy, generalization of trauma triggers to panic and phobia-like behavior. And then there's avoidance. Avoidance of trauma-related reminders, trauma-related thoughts or feelings, social demands. This can also include trauma-related avoidance by substance use or abuse. And then negative thoughts and feelings, overly negative thoughts about oneself or the world, inability to recall key features of the trauma. This and the flashbacks and the nightmares really cause some people to talk about delayed reaction to trauma, or also called post-traumatic stress, as a disorder of memory. You may have exaggerated blame of self or others about the trauma, negative affect, decreased interest in activity, feeling isolated, having trouble with positive feelings. Now, even one or two of these in different categories is enough to impact health and well-being. 5 or 6, one there, 2 there, 1 there, a couple there. And you may, and for a month or more, and you may have a formal diagnosis of post-traumatic stress disorder, which can also seriously impact your health and well-being. This is why delayed reactions to trauma are often simply called post-traumatic stress without the disorder piece. It's because these delayed reactions matter whether or not they result in an official diagnosis. So we've known for decades there's a link between stress and ill health. And we know that trauma exposure is pathogenic. It's bad for you. It's a predictor of immediate and lifetime increases in a wide variety of mental and physical disorders, no matter what age you are, and that there's significant psychological and physiological effects of trauma exposure, even without PTSD. It impacts emotion processing, cognition, mental health. If you experience a trauma level event and don't get PTSD, you're more likely to get PTSD the next time you experience a trauma level event, which is why trauma accumulates over the lifetime. You may have anxiety, depression, substance use disorders. And that's all in any age and any stage of development. So back to the ACEs pyramid. Now we know that trauma exposure at any age can lead to changes in neural and immune function. They can be adaptive in the short term. Being more jumpy in a high environment is probably protective, but it's bad for your long-term health. It can lead to social, emotional, and cognitive impairments and changes. It can lead to adoption of health risk behavior. But again, even without adoption of health risk behavior, you can have long-term impacts on health and on mortality. No PTSD required. So, what's special about the context of aging? All right. So, traumas accumulate with increasing age. I'm not even going to go into the caveats there. Here we have a graph showing that, for example, relationship traumas accumulate with increasing age. more than 2/3 of the oldest old experience the death of a spouse. Here we've got people between 65 and 74 as what's called in sociology the young old. Here are the people between 75 and 84, the old. And here the oldest old are 85 and up. See, of course, that the longer somebody lives, the more chance they have of outliving their spouse, of having a spouse die. And this type of trauma is often endorsed as a lifetime worst stressful event, regardless of their exposure to other traumas like rape or combat or stuff like that. And these traumas, as we see, accumulate with age, as do other traumas. Okay, this is a study at the University of North Carolina alumni. So alumni and their spouses. More than 2,500 respondents of baby boomers, folks born in the 1940s. Mean age about 60 years at the time of the study, mostly white, most finished college. So this is a pretty privileged group, okay? Mean number of traumatic events or trauma level events that they experienced as a group was more than 6. Okay, so these people, just the longer you live, the more likely you are to experience random traumatic events. Getting hit by lightning, getting hit by a car with a drunk driver. And you are more likely to experience death of a spouse or a child with older age, which is highly significant. All of this kind of underscores that trauma exposure accumulates with age. So sources of trauma can just be being old or an older adult. You have accrual, like we just saw, and losses, social losses, and then you have life review. The normal process of life review starts to, have people revisiting their lives in a fairly intimate way. Okay, so I learned more about my father's experiences in World War II in the Pacific in the last few months of his life than I had in all of the other years combined, and that my mother ever knew because she died before he did. This normal process of life review can reactivate old trauma memories. Traumas and trauma triggers stay very tightly associated unless trauma-specific therapies kind of help pull them apart. So they can last for decades, they can last a lifetime. So reactivation of old trauma memories, even if people have been coping well for decades, can reactivate prior PTSD. And this is especially in the context of ill health, cognitive decline, role transitions, people ending up in long-term care, death of a loved one. It can also result in new post-traumatic stress disorder, the full-blown clinical thing, even if the initial trauma did not. This phenomenon was initially called late onset stress symptomatology or loss. I think they renamed it as late adulthood trauma re-experiencing or later, which I guess is a little less negative. Okay, so here's Esther. Our second case. Esther's in long-term care. She has, again, congestive heart failure, COPD, uses oxygen and a wheelchair. Esther stopped sleeping at night. There's no significant dementia, so this is unlikely to be sundown. She stays up all night watching TV in the living room or sitting in the hallway closest to staff. If people make her stay in her room, she turns on all the lights and wakes up her roommate. She's napping on and off during the day, so she's not participating in as many activities during the day. Medical check shows no significant increase in pain. Staff reports incontinence onset at night. No significant other changes. Staff are getting frustrated. So, late at night and talking with a trusted staff person, Esther said she'd been thinking a lot about a puppy she had as a little girl. This again would be some of that life review piece. Okay, she loved that puppy. But one day it peed on the floor and her mother told her father to take it out and shoot it, which he did. True story, stock photo. So trauma doesn't go away just because we get older. Esther did not connect her own incontinence with her puppies. She did not fear the staff were going to shoot her, but she was still distressed, and she was staying up all night to be sure she would use the bathroom properly. It wasn't working very well, which made her more nervous. Just knowing about the puppy helped the staff feel less frustrated and be more productive in thinking about ways to help. So the facility had a consulting behavioral health specialist because of phase 2 of the CMS final rule, and he or she supported the staff in helping Esther understand her own trauma responses. Esther was cognitively capable, and she responded really well to trauma psychoeducation, understanding her own trauma physiology, her own stress reactions. The staff members helped normalize those stress reactions and fostered a sense of kind of control and ability to cope with and accept her own incontinence, which was kind of a normal part of what she was going through. They also sat with her while she grieved the loss of her puppy for the first time. And Esther slowly returned to sleeping at night. Sources of trauma can also include being sick. Intensive medical intervention can be a trauma. Sources of trauma include, for example, critical care. This is going to be a really important consideration in the post-COVID pandemic world. With critical care, you've got sedation, restraint, intubation, light, noise, all kinds of things going on. 80% of mechanically vented ICU patients experience delirium, more than 80%. Up to 50% of all older hospital patients, whether they're in critical care or not, develop delirium. And it doesn't typically resolve by discharge and extends for a number of months. Delirium predicts PTSD, cognitive declines, and 6-month mortality. You see full PTSD in 18 to 34% of all patients after ICU care, which has actually caused the Association of Critical Care Physicians to change how ICU care is done, but you're still seeing some of this piece. Another source of trauma is being treated for cancer. You see PTSD symptoms in 20% of patients with early stage cancer. You see it in 80% of those with recurrent cancer. The NCI, the National Cancer Institute, says, and I quote, "A timely and careful assessment of patients with cancer is critical to identify the symptoms of cancer-related post-traumatic stress, to note the deleterious impact of symptoms on functioning, and to plan interventions targeted at the most distressing symptoms," unquote. The upshot is that trauma symptomology in medical patients matters. From the research, if people have a higher number of symptoms of PTSD, they have higher reports of perceived pain, more anxiety, depression, distrust, and anger, avoidance of trauma reminders, which can include avoiding medical settings and medical personnel if it's medical-related trauma, and decreased patient-staff collaboration and patient care. It's your angry patients sometimes. So stress and trauma at end of life, which is relevant to long-term care, is, okay, you tend to have older people towards the end of life these days. That's just the way the demographics are going. If you're older, you're more likely to have social losses, and you're more likely to have reactivation of trauma memories, and you're more likely to have an accumulation of psychological trauma, just because you live longer. If you're old and you're sick, you're more likely to have reactivation of trauma memories, and then you're more likely to have intensive medical intervention. If you're old and you're sick and you're dying, in other words, you're at the end of life, you're experiencing disease progression. And so that intensive medical intervention can get very intense indeed. And then you may also have failures of that intensive medical intervention. So for example, you're a cancer patient and you've had that team have your back until they don't. They say, okay, now you're done, and you go on to hospice or into long-term care or wherever they want you to go. And that can feel like abandonment and can be pretty rough on folks as well. So all of that makes it more likely that end of life is going to be a locus of medical trauma, reactivated trauma, and post-traumatic stress. So there's all these elephants, and there's this poor lady. So at the end of life, here we all are. If we know this, we can be prepared to help. So these are some implications for clinical care. We're talking about a cultural shift from what is wrong with you to what happened to you. SAMHSA's Treatment Improvement Protocol 57, the TIP 57, provides an approach to trauma-informed care in behavioral health and how to build a trauma-informed organization. Trauma-informed medical care is not quite the same. And we're going to we talk about that in a number of the other videos, including video 4 on trauma triggers. But here's a schematic for how I and my colleagues break down how we reach the goal of person-centered, trauma-informed long-term care. This is for a chapter that we have under review, which this figure is from. So it starts with organizational change to implement universal precautions. For that, see the TIP 57 book I showed in the last slide. I also suggest trauma-specific precautions. If you know or suspect someone has a history of combat exposure, sexual assault, or if they're a refugee, implement precautions to reduce potential triggers for these situations. If you know person-specific triggers, certainly implement those. Implement precautions to prevent hitting those buttons. And there's person-centered screening. So anyway, I've got video 4 of this series is on trauma-specific precautions. We've got 3 other videos that Paige Hector has done on person-centered screening, which we worked through in doing this chapter here. Person-centered screening can be as direct as handing somebody a pencil and paper validated survey for that information. For information on how to do that, see the TIP 57, or it can be indirect. Indirect screening puts the onus on you and your colleagues, staff in long-term care, to know the signs and symptoms of delayed reaction to trauma and figure out if that's what you're seeing. Everyone, whether or not they're a mental health provider, can learn to support somebody in managing their trauma reactions. And then there's person-centered behavioral intervention by a behavioral health practitioner, all with the goal of meeting person-centered trauma-informed goals of care. The idea is for this resident to feel safe in your nursing home or long-term care facility and from their own symptoms, to avoid re-traumatization, avoid hitting those triggers, increase their resilience and trust and their sense of empowerment so they can tell you if something's bugging you, them, or if there's a different way they would like things done that would be more comfortable for them. So person-centered behavioral intervention. We're talking about probably palliative behavioral intervention to reduce symptoms of trauma, not necessarily treat PTSD. And this is no matter how old and sick you may be, making peace with the past. There are 3 gold standard trauma-specific treatments to reduce symptoms of post-traumatic stress. One is their trauma-focused cognitive behavioral therapies. That includes trauma-focused CBT and cognitive processing therapy. There's exposure therapy, and there's eye movement desensitization and reprocessing, which is a mouthful, so most people just say EMDR. Any of these are appropriate if a resident has plenty of time, is healthy, alert, cognitively competent, kind of the average behavioral health patient. The U.S. Veterans Administration endorses CBT, exposure therapy, and EMDR. The World Health Organization endorses trauma-focused CBT and EMDR, but not exposure therapy. If you do not have a resident that has lots of time and is healthy, alert, and competent, use EMDR. And here's why. EMDR, or eye movement desensitization and reprocessing, is brief, it's effective, it's evidence-based in randomized controlled trials in comparison with the other two gold standards. It is equally effective and actually takes a little shorter time to be effective. It includes one session protocol. Some of the flash procedures are 10, 15 minutes and can reduce symptoms. And with people who are really sick in bed, maybe approaching end of life, symptom reduction, reducing the clinically relevant symptoms that interfere with care and are making your resident miserable. That's the idea. It's a more palliative approach. With EMDR, clients typically do not get worse first. There's a very low cognitive demand and no homework. Cognitive behavior therapies typically don't work if people don't do homework. Neither does exposure therapy. There's no detailed description of the trauma as is required for exposure therapy. And there's a lot of formats for the bilateral stimulation that acts as a distractor. With younger adults, you can use eye movements. Typically, you don't necessarily want to use eyes with older adults, because at least the ones I've seen, it makes them dizzy, or some of them. But you can use tapping their shoulders, tapping their hands. I use powder puffs sometimes, or tapping their feet if they're in bed and their feet are intact. Or sound. You can put headphones on that deliver a tone to each ear. And there are modified protocols for dementia and more every day. Someone, as I said, someone who doesn't have a lot of time because they're near the end of life, we may be looking at palliation rather than cure. But even reducing nightmares can be a blessing for somebody who's suffering. And here's Samuel. Samuel's got end-stage bladder cancer. He's got nightmares about combat trauma. He's a World War II vet. He's increasingly depressed and tearful during the day. So this is about an EMDR on-the-spot intervention. So Samuel was a Navy gunner in World War II. He saw a Japanese pilot's face at the moment he shot down the plane. So he's looking, he was at his big gun. The plane came close enough as he shot it down so he could see the pilot's face through the windshield. And that's what he was seeing in his nightmares. A hospice social worker, because this is an actual hospice case, this is a stock photograph, invited, and his name wasn't Samuel, invited Samuel to reflect on this memory while she did some on-the-spot EMDR intervention using bilateral tapping. After 10 minutes or so of bilateral stimulation, he started to calm down. And finally said that he wasn't upset anymore, because he said, I think that the pilot and I were a lot alike, both good soldiers, who really only wanted to get home to our families. Following that very brief intervention, his nightmares did stop, his mood improved, and his slightly off-color sense of humor returned. And, these are resilience resources for him. He could start to think about the future, which is which is something that, as a hospice social worker, that's a positive. People can think about the future even at the end of life. He had been a pilot, and he had a last wish. He realized he wanted to fly again. His hospice found a pilot at a regional sailplane club who flew his motorized glider to a local county airstrip, and it's a crowd of family and friends, and he was lifted out of his wheelchair, gave him the last little hit of oxygen, and off they went. And he had a lovely last flight and died less than 2 weeks later. The little elephant was okay. But this is kind of an example between unresolved trauma. You got a mess here. Or resolved trauma. This is actually a retired elephant researcher greeting an old friend. But here, trauma's going to stand for, the elephant's going to stand for trauma, which doesn't go away just because we get older. but symptoms can be reduced to the point where they don't cause distress and may even serve as a foundation for growth. Making some peace with the past. All the way to the end, you can still do that. Too often, if somebody is seriously ill or cognitively challenged or even dying, it's assumed that they're not capable of receiving evidence-based interventions to reduce the symptoms of stress or trauma. I'm saying here that capacity should determine clinical strategy. In long-term care, you've got people with varying capacities, some of them kind of limited. But capacity should determine your strategy. It should not exclude people from a higher level of care that can provide them with greater ease. Now you know more stuff. What are you going to take back to your workplace with you? What are you going to take into your life? Here's some references that I referred to in the slides. And thanks for thinking about this important topic with me. This is, by the way, a guy who is playing the piano for blind elephants in a blind elephant sanctuary. Anyway, and these are thanks to many of my colleagues who are helping work on developing EMDR bedside interventions. Here's a little bit about me, a bio. Here's how you contact me. Here's how you get hold of the Ithaca College Gerontology Institute. And, this material has been brought to you through a grant from the Care Compass Network in collaboration with the Ithaca College Finger Lakes Geriatric Education Center. Thank you again. Stay safe, be well, and take care. Bye-bye.